Thank you, everybody, so much for joining us this afternoon for our Doctors In presentation on pain management. For any of you who are new to Doctors In, this is a monthly program series offered by the Elder Initiative at the William Wade Community Center and our partners at Jefferson Health. And so each month, having a different health topic with doctors from Jefferson coming in to share their expertise, share their knowledge, and share resources about how to manage various health issues, and with each month having a different health focus. Today being pain management, which is obviously a health issue that affects many people. And so we are lucky to be joined by Dr. Brad Falk, who is making his Doctors In debut with us today. So very good to have you with us, Brad. Before I turn it over to you, just a couple housekeeping things for folks in attendance here on Zoom. At any point, you can put your questions into the chat, or you can use the Q&A feature in the toolbar at the bottom of your screen. One thing to note, when you do put things in the chat, your name does come up with it and is seen publicly. If you have anything that you would prefer to ask anonymously, you can use the Q&A feature. And there is an option to keep your name off of your question. So if you are sharing anything more personal, you're better off using the Q&A and asking your question anonymously. We are also live on Facebook. So anyone who is watching us on Facebook, you can just put your questions in as a comment, and I will check the Facebook page periodically and relay any of those questions to Dr. Falk. And then Dr. Falk, if it's okay with you, I can just sort of chime in if there are questions coming in, and that way you don't have to watch the chat, or if there are places that you plan to kind of pause to take questions, we can do that as well.
Okay, yeah, no, that's great. That way I can just interrupt me whenever.
Perfect. So that being said, thank you again to everyone, and I will turn it over to you, Brad, to get us started here.
Great. Well, thank you for having me. It's an honor to be able to speak with everyone. I'm sorry that it's in such a impersonal venue. It's always nice to be with folks, but I think we've all sort of acclimated to this style of interacting now. So please, just because we're not sitting in the room, please, like David was saying, just call out whatever, put a thing in the chat, whatever. This is a very informal talk on my end, and it's really meant to spur discussion and questions. So please don't feel bashful about interrupting and asking, and that's why I'm here. So a little bit about what we're going to talk about. The title gives it away. We're going to be talking about pain management, which is obviously a really broad topic. Pain management is like, people do fellowships in pain management. So this is an incredibly vast, broad topic, and we really could talk for days on this and go down various rabbit holes and get really granular on some of this stuff. My hope for this talk and the purpose of our discussion today is really for you all to have a chance to speak with a doc and ask questions that you may not think to ask when you're speaking with your providers, questions that you've always had that just never came up. There's no question that's too simple or too complex. Well, there are definitely some questions that are probably going to be too complex, but please don't be embarrassed about the level. I'm assuming that we have a wide array of knowledge bases here, from total layperson with a very basic knowledge and understanding of pain management on the medical side of it, to folks that may be listening who have very advanced medical knowledge. So, and please, any and all, there's nothing that's too out there to ask. So with that said, I want to give you a little information about my background so you understand my perspective on this topic. I am currently a palliative care fellow at Jeff, and that's a 1-year fellowship. However, I'm an old doc. I've got grays. So I've actually been an ER doc for around 20 years. So I've been around the block with managing pain for sure, but fairly relegated to the ER setting in that context, which it's interesting because I felt that I'd sort of seen it all in a sense. And then I came here for this year of fellowship, and it's pain management takes on a whole new meaning, and there's a whole different context and a different approach. And it's been very meaningful and enlightening for me to see this different approach. So I'm sort of with you guys in the sense that here I've been managing it for 20 years and sort of been on the quote unquote expert side of pain management. And here I am now in the learner side again. And so point being that there really is no such thing as expert. We're all learners. There's different approaches, and there's no one size fits all. So let's dive into it, because I've got a lot to cover. And David, you let me know how I'm doing time wise, and if I just sort of threw a bunch of my thoughts down, and I'm really not. I hope it doesn't go over, so we can. You can sort of pace me as you see fit. How do I? It's not letting me advance here. There we go. Oops. Oh, whoa, whoa! How do I get back here? I'm used to Teams. Ugh. How do I get back?
You should be able to cycle just with your arrows.
Yeah, it's not letting me do that. Oh wait, now it's working. Okay. All right. Well, I've totally blown the whole talk now.
A couple spoilers in there, I guess, right?
Yeah. Okay. Wow. All right. So it turns out, I'm sort of saying this tongue in cheek at the top. Turns out that a lot of people have pain. Pain is like one of the number one things that we see in the ER for sure. I mean, people are coming in for acute pain, for chronic pain, for all sorts of kinds, traumatic pain. There's all sorts of things that can lead to pain and people presenting to the ER, and that's what I'm typically used to. But the numbers are astronomical. So around 20% or 50 million U.S. adults live with chronic pain. I mean, think about that. That's almost one in 4 people in the U.S. live with chronic pain. 8% of U.S. adults, or 20 million people, have high impact chronic pain, meaning that it really affects their lives. This isn't just pain that they're able to move on and live with. This is really impactful. It's interfering with the quality of their life and their functional ability. Pain recently the study and research and academic focus on pain has really come under scrutiny for the historical underrepresentation of various groups. So elderly, people of color, LGBTQ, intellectual disability, unemployed. I mean, I think just like we're seeing in essentially every silo of medicine, there has been systemic underrepresentation and disregard for groups of people, for minority groups, and for underrepresented folks. And so as a result, a lot of the research that we're basing our treatments on don't include these groups. And so what's concerning is a lot of our treatments may not be applicable to someone because they haven't really been studied. So this is an area that is really under scrutiny now, is just the inclusion and equality in research so that we can apply treatment to the general population, not just a select few. So I don't know if you can see this. I have a thing covering up, but I have a silly slide here for anyone who likes Family Guy. Everybody recognizes pain, but can they define it? And it's one of those things where everybody knows what pain is, but if you're asked to define it, that gets more challenging. There's many different definitions of pain, and it's different for everybody, and it can be a very personal, contextual thing. So I just wanted to, boy, I'm having trouble with my arrows here, but I just wanted to show the actual Merriam-Webster definition of pain. So there's two main definitions. One is the localized or generalized unpleasant bodily sensation or complex of sensations that causes mild to severe physical discomfort and emotional distress that typically results from bodily disorder, such as injury or disease. Okay, that makes sense. The second definition, a basic bodily sensation that is induced by a noxious stimulus, is received by nerve endings, is associated with actual or potential tissue damage, is characterized by physical discomfort such as pricking, throbbing, or aching, and typically leads to evasive action. So the basic theme is there's something that may or may not cause tissue damage that causes a stimulus that we react to, and it's generally a negative reaction. And that's going to, I'll come back to that in a second. So we've got some typical, I included some pictures of typical pain. So call out what you think hurts for these folks that I'm going to show you. All right, David, you're in the hot seat because I think you've got the mic, right?
Back.
You got it. Wow, you're what do you think she's got going on?
Head, migraine, something in the brain.
I'm going to say headache as well. Oh, whoops. I think well, for some reason, the slide thing is, I'm jumping all over the place. What do you think she's got going on?
I would say it's a little hard to tell. This looks like someone who might be more in emotional distress.
Yeah, emotionally distressed. And that's one of the things that, like, we were talking about how research on pain management has been focused on typically the more represented members of our population. In a similar way, pain has been focused on that sort of tissue damage idea of what pain is, that sort of Merriam-Webster definition of pain. But she's in pain and she's got emotional pain. And we're going to talk about that a little bit later. And that's a large part of what we do here at palliative medicine. And we'll come back to that. But that's something that we do recognize is every bit as painful as other types of classically defined pain. So there are three types of pain. And I wanted to introduce some of these medical terms because these are some of the things that you're going to hear from your doctor, from your medical team, and they'll refer to these types of pain. And I think these are helpful definitions just to kind of be familiar with, so that people aren't talking above your head. And if you hear them mention some of these terms, you're like, I know what you're talking about, and I disagree. Or, so I thought it would be helpful to kind of go through some of the vocabulary. So there's three types of pain in general. Can anybody name some descriptors or types of pain?
And folks can put things in the chat.
It's okay. I don't want to torture people. I hate when people. What's that?
Achy.
Liz Spina, who I think you've met before.
Yeah. Hey, Liz.
She just yelled out achy, and that is not one of the definitions that I'm going to include. Okay, so I'm going to go off of. We're going to just move on. You don't have to put in. Oh wait, I see that people have put in. Let me pull up the chat.
Yeah. So someone said a throbbing pain.
Throbbing. Okay, so Liz says aching. William says throbbing. I'm actually a little bit more general than that. So you're getting very specific, which is good. I'm talking about some of the basic descriptors of, I think actually descriptors is the wrong term, more categories. She's nailing it. Liz is nailing it. I don't know if you can hear, she's answering it all. She's a palliative fellow, so she better get these right. So you'll hear people refer to acute pain. And again, I don't want to offend people's knowledge and intellect, but you'll hear people talk about this. And I'll tell you, there are I've had residents that have really misunderstood the difference between acute and chronic or subacute pain and stuff like that. And it's an important differentiation because it really does change how we approach and manage these kinds of pain. So acute pain is typically sudden onset. It will usually be transient, meaning that it's going to come on and then should go away, sort of by definition. It's usually associated with an acute process causing tissue damage. So this is what we think of with a broken bone or appendicitis, and typically it's associated with distress. And here you can see the picture of the cartoon of Homer at the bottom of a cliff. And he's probably experiencing, if he still has vital signs, he's probably experiencing acute pain. So then we talk about chronic pain. And chronic pain is very different in how it affects a patient and how it's treated or should be treated. Chronic pain is typically long lasting. You'll typically see patients with what's called exacerbations. So they might have, think about someone with gout who has a gouty ankle, let's say, or a gouty foot, and it really causes a lot of pain. And that's an acute component of their chronic gout pain. So it can last a couple of days, it eases up, and then they could have another exacerbation of that pain a couple months later. But typically, you would say that that person has chronic gouty pain with exacerbations. So you might hear your team talking about exacerbations, and now you kind of have a little bit more context there. Typically, chronic pain results from chronic medical conditions like arthritis, like osteoarthritis, Crohn's disease. We see a lot of chronic abdominal pain with that. Neuropathy can cause chronic pain. So folks with diabetes will get peripheral neuropathies, which can be very distressing and lead to chronic discomfort. HIV, you can have neuropathy, post-chemotherapy. So a lot of processes can have a similar end result of chronic pain, which is can be very distressing and life-altering for people. So we also differentiate pain based on the cause of the pain. So we will refer to pain, and these are some terms that actually some physicians may not even hear until fellowship. So these are loftier terms, but you might hear someone talk about nociceptive pain. So nociceptive pain is usually from tissue damage. So that might be from, say, a bee sting, broken bone, a burn. Cancer, when it causes tissue damage, can result in pain. That can be acute or chronic, but typically nociceptive pain is going to be chronic. You can classify it by anatomy. So for instance, you'll hear this commonly, musculoskeletal pain. And you'll hear your doc say, I don't know, you just have some musculoskeletal pain. What does that mean? It's basically referring to pain involving your body, the muscle and your bones. So typically sprains, contusions, that will have that umbrella term of musculoskeletal pain. Very non-specific general term. You'll hear people refer to arthritic pain, which refers to the joints. So that's gout and osteoarthritis. Myofascial, where you're talking about trigger points like in fibromyalgia. So there's a lot of different terms that are floating around. But again, the biggest differentiation, the biggest divide is between acute and chronic in how we manage. So anybody can look at this guy, and if you look down at his feet, how might you describe, would you say that's acute or chronic at this point?
I'd say that looks awful, but acute.
So he's got acute nociceptive musculoskeletal pain. And his foot is going the wrong way. And so these are the kinds of things that I would typically see in the ER. And which is why I mentioned that the approach this year with folks with more chronic cancer-related, chronic illness-related pain has been very, very different, very enlightening. So again, I think we can kind of blaze through this. This is talking specifically about neuropathic pain. Basically, nerve-pathic disease. It's nerve damage pain. So neuropathy can be caused by so many different things. It's the sort of common final pathway for so many different processes, some of which we mentioned before, like vascular disease, specifically caused by diabetes, where you have microvascular disease that damages the nerves. Infectious, like HIV. Shingles is a big cause of neuropathic pain, and people can have very chronic pain, chronic neuropathic pain that's very distressing following shingles. And then trauma, you can actually have physical disruption or damage to the nerve, like if you're in a car accident, you actually have a deep laceration or something that actually damages the nerve. So lots of things can cause it, but you'll hear people refer to neuropathic pain. And the reason why it's important to differentiate is because the treatments that are targeting nerve pain can be somewhat specialized and different from the treatments that target just generalized musculoskeletal pain. So I also wanted to include something that can be somewhat controversial and is very often overlooked, but something that's you'll hear referred to as functional pain or psychogenic pain. This is really tough because this is a very hard pain to quantify. It's pain that is either caused by or augmented or affected by psychological factors. So psychogenic pain can and often does have physical origin that is perpetuated by psychological process. So for example, someone with a traumatic experience and an injury with pain lasting longer than one might expect given the typical injury and healing trajectory. It can often be associated with anxiety, fear, depression, and stress. So, you can also have primary psychogenic pain that does not have a physical origin. I'm bringing this up because historically the medical community has really discredited this entity, and unfortunately, patients who have psychogenic pain have been mismanaged or altogether not managed. And the fact is, we often talk about common final pathways. Just like someone may have pain that has a neuropathic or a nociceptive etiology or origin, people who have pain may have a psychogenic origin, but that doesn't mean that they still have pain that is really negatively impacting them and causing them distress, and that needs to be addressed. So I think we've really wronged a lot of people historically in how we manage this, because we've really invalidated it for many, many years. So this is something that we are paying more attention to now and trying very hard to destigmatize. Okay, so we just went over the definition of pain. So I put up here, so we can define it, but how do we treat pain? This is the part of the talk where I'm hoping that those of you who are here because they want to hear some nuts and bolts of basic pain management, this is that part of the talk. So slow me down, ask questions. This is really the part where I want to provide information that is of practical use to people at home, in hopes that you don't feel that you have to reach out to your doctor, that you have more control over your primary pain management at home without needing to reach out. So
I'll give you, Brad, the question that has come in so far, because I think it's going to segue into what you're going to be talking about now, but looking for recommendations for over-the-counter pain relief, knowing that there are some side effects, so ibuprofen maybe being bad for blood pressure, and also that there are a lot of things seemingly that have similar purposes, but hard to tell between these different brands. So if you can touch on that as you go into this next section too.
That's a great segue, and yep, that's the kind of stuff we're going to talk about. So with pain management, I want everyone to remember, and this actually goes into exactly this question: one size does not fit all, and that's sort of, I don't mean to weasel out and say it depends, but it depends. And there's lots of considerations for every single medication. And we'll come back to this because these are really super important points that I think if there's one question that I predicted would be asked, it was this exact question. And I hope to answer that. And if I don't cover it enough, we can absolutely spend more time. So let me just get kind of forward to that area. So in terms of pain management, in general, we have pharmacologic, like medications, and non-pharmacologic, which is basically everything else that I'm gonna mention a few of those non-pharmacologic approaches. So pharmacologic, what are we talking about? Well, some of the pharmacologic approaches, the question, the asker, the chatter just asked, and with Motrin, with Tylenol. But there's actually so many classes of meds out there. So yes, we have things like topical medications, like lidocaine patches. We have all of the over-the-counter stuff like the NSAIDs. So that's when we're talking about Motrin, Advil, Naprox, Acetaminophen, which is Tylenol, and aspirin. Then we have prescribed oral pharmacologics, prescribed oral medications like opiates. This is just an intro slide. We're going to spend a little bit more time talking about these specific classes in detail. And then we have advanced pain management. And I just wanted to introduce this and show this. We're not going to go over this stuff in detail, but these are the kinds of things that we deal with when it comes to higher levels of complicated advanced pain management. So things specifically targeting neuropathic pain. Things like transdermal opiates, like fentanyl patches, you'll hear about. Sublingual, like Suboxone, can be used for. A lot of people hear about Suboxone in conjunction with opiate use disorder. Well, we actually use it for pain management as well. There are inhaled medications. There are intravenous, obviously intravenous medications. There's even intrathecal medications, which are medications that are infused into your central nervous system. So pain management can be very, very advanced. And I also just wanted to mention that medical cannabis is a big thing now. And I'm sure several folks in this discussion utilize medical cannabis. It's very common, increasingly so. We actually prescribe a lot of medical cannabis here at Jefferson. I think we're kind of one of the main centers in Philadelphia that has the medical cannabis program. And it's really been shown to be very effective and helpful, especially in folks that are really challenged by complicated pain where they might be maxed out in certain other classes. So medical cannabis can be very helpful and just be another avenue of pain management in folks that are really suffering from complicated pain. So again, I'm just going to talk about the circled stuff. This is going to be pretty basic. So in terms of non-pharmacologic, I don't want to spend too much time talking about this stuff, but a couple things. Everyone, you learn from a young age, you fall, you twist your ankle. The first thing you do is put cold compress on it, right? You elevate it and put cold compress. So temperature management, that's non-pharmacologic, but very effective. So cold, heat, there's different times that you want to do. Initially, typically, the more acute the pain is, you're going to want to stick with cold to help reduce inflammation. The longer ongoing the pain is, once the acute inflammatory phase has resolved, you can think about doing more heat. But there's a lot of opinions on that. That's really not an evidence-based kind of thing. Ask 5 different docs and they'll have 5 different theories about that. So that's kind of the way I learned it and typically what I tell my patients. Massage is a very utilized non-pharmacologic management of pain. Physical therapy, electrical nerve stimulation therapy, manipulation, hypnosis, acupuncture, Reiki, all the mind-body stuff. So yoga, Tai Chi. And then there's the creative arts therapies. I would have included this no matter what, but I have to also put in the plug that my wife is a dance movement therapist. And so we talk about this a lot in our family. And I am amazed at some of the stories she has about very complicated patients that have very complex pain syndromes, who there's no question in my mind, she has really made a difference in their lives through movement therapy, dance movement therapy. And I just want to also say it's not always dance. It's sort of more appropriate to call it movement therapy. And she works with people in wheelchairs, quadriplegics, moving their facial muscles. There's all sorts of stuff. So I have so much respect for non-pharmacologic approach to pain management. And again, this is one of those things that we're really unearthing so many things that in academic medicine have been poo-pooed over the years. And no question about it, this stuff has not had the spotlight shined on it in terms of research. It's hard to quantify. It's hard to do, but there's no question that it really, really helps folks. So this is something that we incorporate a lot in our cancer patients. So we try to introduce a lot of these different things as options for them. So how to manage pain really depends on, again, we go back to acute versus chronic. Is it nociceptive versus neuropathic? Is it organic, meaning coming from tissue damage, versus functional, like the psychogenic pain? Because obviously the way you manage them is going to be different. So let's pick a couple examples to go through for context. And I tried to pick some things that are probably, more likely to be encountered. So 56-year-old with sprained ankle. After, I can't even remember what my thing is covering it, after tripping. Okay. So just in the interest of time, let's, we don't need to shout it. I think Zoom is sort of inhibiting our ability to shout things out. But this goes back to what we were saying before. You can put ice, you can do elevation. So we have the acronym RICE, rest, ice, compression, elevation. So you fall, you trip, something's swollen and it hurts, RICE. Rest, take it easy, try not to walk on it or use or weight bear, which includes any of your limbs. Get a cold compress on. In general, don't put ice directly on your skin. You can actually cause thermal damage. Usually just put ice in a paper, in a towel or an old t-shirt or something, and just have sort of indirect cold application. Compression, it can be helpful with acute swelling to put an ACE on it to help reduce compression, but the biggest thing is going to be elevation. I actually really caution patients against the compression part, and that's classically what's taught, but people can get a little overzealous with compression and actually cause additional trauma. So in terms of over the counters and what meds we're talking about, again, NSAIDs like Motrin, Advil, ibuprofen, they're all kind of the same thing. And then you have other NSAIDs like Naprox and Tylenol. So this is getting back to the original question, which is, okay, that's great, but like which ones to take, and everything has side effects. Like, I don't know what to do. And you're absolutely right. So I'm hoping that people like me are old enough to know, to get this reference. Liz, do you get this reference?
Poison Help.
Do you know who that is? That sticker? Mm-hmm. All right. That's Mr. Yuck. Does everyone remember Mr. Yuck? All right, so I just aged myself. But anyway, Mr. Yuck, it was a huge Tox Center campaign back when I was a kid, so early 70s, and all through the 80s. And these stickers were everywhere on toxins and poisons throughout the house. So you'd put it on your cleaners and stuff like that, so that kids didn't get it. They could see this and it was recognizable, and they'd say, "Oh, it's Mr. Yuck. I can't drink that." But anyway, all physicians take an oath to do no harm, and every medication that we prescribe does have the potential of causing harm. It doesn't matter if they're over the counter. People overdose on acetaminophen all the time. That's something we see commonly in the ER. Motrin can be very harmful. So anything taken in excess or in a physiologic setting that where its metabolism is different, if you have underlying medical conditions that make it more dangerous to take, any of these things can cause real damage and real injury and even death. So let's talk about some of the specifics of what I mean by that. So NSAIDs, these are the go-tos. This is what everyone says. Go take some Advil, take a Motrin. And just remember, be careful when you're talking about different drugs, because there's the generic name like ibuprofen, and then you have your trade name like Advil. So Motrin, Advil, and ibuprofen, they're all ibuprofen. So you just want to be very careful because you don't want to take Advil and Motrin thinking you're taking two different drugs. You're taking the exact same drug. So always look at the generic name and make sure that you know what you're taking. Naproxen is another NSAID that's different than ibuprofen, typically given less frequently but lasts longer. Aspirin is also an NSAID. So the reason people get antsy about NSAIDs is, again, they are great medications and they are absolutely the first go-to for many things, but they can often cause minor things like just an upset stomach, but they can lead to things like ulcers and GI bleeding. So I have had patients show up to the ER bleeding out, and it turns out they were just taking a lot of Motrin regularly, and they had horrendous bleeds. Now, a lot of them have other underlying conditions which will make them more susceptible to some of these, but anybody can have GI badness if, from taking these things. So again, some of the major issues are things like renal bleeding, kidney damage. So taking too much ibuprofen more than prescribed can cause kidney damage, or if you take it and you have underlying kidney disease, or if you're taking it and you're, say, very dehydrated. So, you just want to be very careful because you can cause things. Now, NSAIDs they also have been associated with heart disease, strokes, and high blood pressure. So, where I would send the 35-year-old that comes in with an injury, I don't think twice about sending them home with a script for ibuprofen. I absolutely sit back and think with my 73-year-old, how are their kidneys? Do they have a history of GI bleeds? Do they have underlying hypertension and heart disease? Because these are not the folks that I'm going to be very excited about putting on an NSAID. Now, anything is usually okay for a couple of days. So if you have these conditions and you hurt yourself in general, and I don't want to give a blanket one size fits all answer, but in general, it's okay to take them for 2, 3, 4 days. We're really talking about if you're taking these medications for more than a week, 2 weeks, 3 weeks, that's where you're running into trouble. So I think if you're planning on taking an NSAID for more than 1 or 2 days, I would bounce it off your doc and call your doctor and say, hey, just so you know, I'm having this ache, whatever pain, whatever you're taking it for, is that okay if I take it for a couple of days? Because people can get into trouble with these things. So these are some of the conditions or some of the characteristics that I would be mindful of with NSAIDs. So if someone is greater than 65, if you have underlying kidney issues or GI issues, so someone who has ulcers, you want to be very careful. Probably not the medication for you. And again, anyone with heart disease, stroke, hypertension, if you're on blood thinners, because it can cause and it can exacerbate anticoagulation and make people more susceptible to bleeding. So just because it's sold in CVS doesn't mean it's safe. But in general, it's very well tolerated, and I don't want to scare people off, but just be careful. Acetaminophen or Tylenol, very well tolerated. Usually in folks for whom I have the concerns with NSAIDs, I will turn to acetaminophen. You want to be careful in folks with liver disease. So if someone has hepatitis, with associated liver disease, you want to be careful about acetaminophen. That doesn't mean you can't take it. People who have had liver transplants can take acetaminophen. It's not that you can never take it. You just have to be very careful about how much you take. There will be a less of a daily dose that's tolerable, that's permitted. So if you have underlying liver disease, absolutely talk with your doc before you, or nurse practitioner, whoever you see for your primary care, to ask if it's okay to be taking Tylenol. Now, in general, assuming you don't have liver disease, in general, people can take up to 4 grams a day. So you're talking about 1,000 milligrams. So typically they come in 500 milligram tablets or gel caps or whatever. So you can take like 2 of them 4 times a day. So generally 1,000 milligrams 4 times a day. Usually for older folks and for medical purposes, we usually say greater than 65. we usually say 3 grams is a safer ceiling on how much you can take a day, just to allow for a little bit of reduced liver function so that you don't end up getting into trouble. That's a fairly recent change. So you might notice that your docs are now saying 3 grams, and that's where it's coming from. It's been the past couple of years that people are starting to shift to 3 grams. So how are we doing on time? We got.
I was just going to cut in and give you a warning. So we're at 12:45, and I want to leave a little room for questions. So if you want to maybe take another 10 minutes and highlight kind of your most important content, and then we'll get some Q&A at the end.
I'm going to skip this. This just I geek out a little bit with the toxicology of how acetaminophen hurts your liver. You can contact me separately if you're curious about that stuff, because I really want to get into this. I think any talk on pain management would be really insufficient without mentioning the opiate epidemic and sort of the responsible prescribing of opiates, because this is something that obviously comes up all the time. There's an incredible amount of stigma associated with it. I actually just took care of a physician who is now a cancer patient who said he's really struggling with the fact that he's on opiates because he has been quote unquote medically raised in this system where it's so taboo to take opiates now. And there's so much stigma that every time he says, I'm really having a lot of pain, I'm having more pain, I think I need to go up. He worries about the optics of that because he knows what it's like to be on the other side and what people think. And that was really heartbreaking to hear. That said, there is very good reason why people do need to be responsible and careful about opiate prescription. And I want to back up a little bit and just say, when I came up in medicine, I went to med school in the late 90s. I did my residency in 2000 and finished in 2004. So this was at the time, I think it's my next slide actually. Yeah. So this was kind of where this whole thing sort of started coming from, right? So in 1996, the American Pain Society came up with this idea of the 5th vital sign, right? Pain. Pain is the 5th vital sign. CMS, which is the Center for Medicare and Medicaid Services, said, aha, okay, we want to tie reimbursement to patient satisfaction regarding how well their pain was addressed. Okay, does everyone get that? We're going to basically dangle a hospital or provider's reimbursement based on how well the patient said their pain was managed. At the same time, you have providers being very much encouraged by their hospitals now to prescribe drugs which are going to make the patients satisfied and happy and give them good grades. And at the same time, you have Purdue and Big Pharma that are coming around and doing lunches and taking people on vacations and conferences and saying, OxyContin, it's our new long-acting opiate, which is extremely addiction-proof, and all sorts of other opiates, but OxyContin is the big one. It was an incredible convergence of variables that led to the perfect storm. And it really was truly a perfect storm that we are still dealing with very much today. So this slide kind of shows you that it's not just OxyContin in the late 90s and early 2000s, right? So here we have, these are the deaths per 100,000 population. So here we have the early 2000s, and we can see that basically deaths from any opioid are starting to increase, right? People are starting to use heroin more because they're not able to afford their OxyContin. They become addicted and then they can't afford it and they turn to heroin. And the other synthetic opioids like tramadol and fentanyl are kind of cruising along. And then here you have this precipitous jump. And this is where we start seeing the introduction of synthetic opioids like fentanyl being aggressively introduced into our market as a substitute to not only the various pills that people are taking, but also to heroin. It's now an adulterant in so many, like it's now essentially like a pharmacologic contaminant in so many drugs. So people are buying weed and thinking that it's just straight up marijuana, and then there's fentanyl in it, and we're seeing those overdoses in the ER. People who didn't even know that they were doing opiates. Very, very scary. So I wanted to point this out because everyone has heard this a million times about how the deaths are, precipitously increased, but here we're seeing a real disproportionate rise in these synthetic opiates like fentanyl and tramadol. And I wanted to point this out because a lot of people don't consider tramadol an opiate. And so tramadol is also called Ultram, and it is a complicated, messy drug that does stimulate the mu receptors that makes it an opiate. It is an opiate. People in the early 2000s were like, you know what, we want to let's start moving away from OxyContin and all the other typical opiates. And everyone embraced tramadol because it didn't sound like an opiate. It wasn't really considered an opiate. In fact, you didn't even need a DEA license to prescribe tramadol. But guess what? People overdose from it. It's an incredibly metabolically messy drug, so people can take it and react differently to it than they did before based on certain physiologic parameters. It's a very dangerous drug, and I see a lot of patients still on it, and it makes me very nervous. It also has all sorts of effects. It can give people serotonin problems like serotonin syndrome. So if you're taking something like fluoxetine or Prozac, and you also take tramadol, you can have serotonin syndrome, which can be deadly. So if there's one thing you walk away from, please, 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 I want you to, if your doc says, you know what, I'm going to put you on Ultram, that's safer than morphine. It's not. It's actually messier and potentially even more dangerous than morphine. So be careful with that. A lot of community docs haven't gotten the memo on that. Where was I going with this one? Takeaway regarding opiates for non-cancer related pain. Oh, I just wanted to make the differentiation. So this year I'm seeing a lot of cancer patients, and when we palliative care is really we care for folks with advanced illness, with end of life illness. That's a different category. And when you're talking about someone with widespread metastatic cancer, that's a different category. We're not worried about addiction, right? And people have to remember there's a difference between dependence and addiction. So almost all of my patients are dependent on their opiates. If you stopped it, they would have withdrawal, but they're not addicted to it. Addiction implies a pathologic behavior. So I just wanted to kind of point that out, that if you are unfortunate enough to develop a serious illness or with very real, horrible chronic pain like metastatic cancer, please, please, please do not be turned away and steered away from opiates because of the stigma of what's going on with the opiate crisis. That's apples and oranges. It's a totally different. Putting someone on OxyContin because they sprained their ankle, you can't even compare that to putting them on oxycodone or OxyContin because they have bone metastases from their prostate cancer. So I just wanted to make that point that, again, I come back to there's no one size fits all. It's very contextual. Okay, I think that was basically the point of this slide is try to avoid opiates when it's non-cancer related, not appropriate for a sprained ankle. So I wanted to throw this in real quick. These are always things as an ER doc that I wish I could talk about with my patients. When should you go to the ER? When is pain bad enough that you should reach out and call your doc? So I want to talk about some red flags. So if the pain is unexplained, if it's a bizarre pain, you have no idea what caused it, it's sudden, it causes you concern. Like if you think this is concerning enough that you're going to be up all night worrying that you might die, go to the ER. That's okay. Like that's reasonable. And I hope it's nothing. And I say to my patients all the time when they show up to the ER and they're like, I feel so stupid. No. You were worried. You came here and I'm really, really happy to tell you that you don't have anything that's life-threatening. Now, that said, we do have a lot of folks that show up to the ER, and a lot of these folks are regulars and we know them on a first name basis, that show up with exacerbations of their chronic pain. And it's frustrating because it's like, well, wow, you could have called your doc for this. So I'd say if it's a predictable pain, sort of oh, here we go again, a here we go again type of pain, don't go to the ER for that, unless you're in so much distress you can't function and it's a Saturday night at 10 o'clock and you're just freaking out. In general, it's just not appropriate for an ER to be prescribing meds, especially opiates, for chronic pain. And that gets very messy. There's a lot of comfort, So I would say to avoid any pitfalls with that kind of, I would say don't go to the ER for chronic pain if it's something that's predictable. If it's an exacerbation of pain you've had before, try to stay in touch with your primary care so that that's being managed longitudinally in a responsible way. And okay, so a couple quick things. Do I have another 1 minute?
You do. Yes, go ahead.
All right. So red flags. So back pain. Everyone's got back pain at some point. So red flags for back pain. When should you reach out and talk to your doctor about back pain? So things like fever, unexplained weight loss. If you notice that you have a new back pain and it's waking you up at night, that would be a reason you'd want to reach out and talk to your doctor. Certainly any neurologic symptoms. If you have back pain and you also notice like, that's weird, you have this sort of, you have a foot drop or you have numbness or you're having issues with bowel or bladder incontinence, anything remotely neurologic plus new back pain, or even if it's longstanding back pain and then you develop neurologic stuff, talk to your doctor about it. Don't wait on that. New back pain in someone over 65, we always want to screen for cancer. Usually in the ER, someone comes in and they're like, I've never had this pain before and it woke me up tonight. They're at the very least getting x-rays to make sure they don't have big metastatic lesions in their spine. And that's not the end of their workup, but that's at the very least. So any history of cancer and you have new back pain, make sure your doc knows. So that's it. Questions? What didn't I cover? Or what can I explain? What can I go over better?
That was all great. Thank you so much, Brad. And we'll take some time, folks. You can put your questions into the chat or in the Q&A or as a Facebook comment. I was just thinking, Brad, we didn't even let you get a sip of your coffee. I think that was so much info.
No, we're good. No, it's my fault. I should have had less slides and built in a coffee break.
No, it's wonderful. I'll just to get things started. I know one of the things we've talked about in past Doctors In programs is sometimes when pain is a symptom of some chronic health conditions, that sometimes there are medications prescribed just to sort of treat those symptoms. And it's come up that therefore people feel like they're taking more and more meds and sort of overwhelmed at the number of pills that they've maybe are having to take on a daily basis. So I'm wondering if you can talk at all about sort of pill burden and how it might relate to pain and management of chronic illness.
Yeah, that's a great question. In fact, David, I mentioned I was in a patient's room and then I realized it was almost noon and I had to run back. But that was exactly the conversation I was having with the patient, because they have been started on so many medications that was their concern. They said, I'm treating this to treat this, to treat this, to treat this. Now I have a plate full of medications that I'm taking. So pill burden is a very real thing. We worry about polypharmacy, meaning that, if you're like I mentioned before, if you're on fluoxetine and then all of a sudden someone says, take Ultram, well, you have to worry about how these things interact. And so when you start talking about multiple medications, that's a very real concern. And absolutely these things interact with each other. Some medications inhibit or speed up the metabolism of other drugs. So these are real things. I think it's hard to say in terms of to give you an answer. There's so many, it's very contextual. Obviously getting back to the example of the person with metastatic prostate cancer who has mets all through their spine and pelvis, they're going to need real meds and they're going to need several different medications. I've got one patient right now who the last thing he wanted was to be started on more medications, but he's suffering. And so we have him now on a fentanyl patch and oxycodone for breakthrough pain. And that's just, in a perfect world, I would love to only do one medication but we have to, it's very complex. Pain management can be very complex, and unfortunately it does often come with increased pill burden. So we try to reduce other pills that aren't essential. So for instance, the person that was, their doc threw them on Remeron so they could get better sleep, or like this guy that I was just talking with was started on a really wimpy dose of gabapentin once at night. So it's not really doing anything for him. It's just one more pill. And so we really do try to reduce pill burden and the potential for polypharmacy, prioritizing things like opiates and pain meds so that we are responsibly and adequately treating pain. You just have to prioritize and say what's essential, what's not essential. But that's a very real, reasonable concern. And I think that people can really advocate for themselves when they talk with their physicians or primary care providers and say, gee, I'm really bothered by how much medication I'm taking. Is there anything here that we can go through and kind of weed out that's not essential?
Well, Brad, you just mentioned gabapentin, and there were two questions that came in at the same time, one in the Q&A and one in the chat. So both on gabapentin, but it's a two-part question.
Yeah.
So the first comment from someone saying that they have neuropathy, but the gabapentin was making them dizzy and stumbling. So asking if there are any other similar medications that wouldn't have those side effects. The second question from someone about gabapentin was that it had been working for managing pain for the last 5 months, but now this person feels like their pain is coming back. So should they ask for an increased dose of gabapentin?
These are great questions. So for neuropathic pain, a lot of times the first go-to medication will be gabapentin. The problem with gabapentin is it very, very frequently causes exactly what you're reporting. People feel like they're stumbling around, they feel loopy, they just feel groggy and out of it, stoned. So it can be an amazing drug to help with neuropathic pain. Unfortunately, it sort of has this double effect of coming along with these negative side effects. So there are other medications. Unfortunately, they typically cause similar things. So people will talk about Lyrica and other medications that can be helpful with neuropathic pain. It's sort of a trial and error thing. Some medications work well for, someone says I felt terrible on gabapentin, and then I was switched over to Lyrica and I felt better. We actually, believe it or not, we use methadone for people who are really have really complicated high dose pain medication requirements. Methadone even helps treat neuropathic pain. So the answer is yes, there are different approaches. Unfortunately, there's no magic bean that is really known to be better in terms of side effect profile. It's really very individual, and it's just a little bit of trial and error. In terms of habituating to these medications and, yes, I was on 600 and now it doesn't seem to be as effective. People absolutely, their bodies do get used to these meds. And so you may need a medication increase. And we do that all the time. Gabapentin usually is underprescribed. And so we will typically see people on 300 milligrams three times a day. People who have like really bad neuropathic pain, you'll see them coming in like 300. So they're on 900 milligrams a day. That's actually kind of still a wimpy dose. And so believe it or not, we crank them up if they can tolerate it. So I would say this, at 600 milligrams, and you're saying it was working, now it's not working, I think it's very reasonable to talk to your doctor and say, should we try an increased dose? Because I still think you have a lot of room at 600 to increase your dose, as long as you're not negatively affected by the side effects that are affecting the other person with the stumbling around. I mean, gabapentin can really knock people out. And we get nervous about people driving with it, operating machinery. So it can really bowl some people over and be very negatively impactful. Other people respond really well to it. So very, very individualized management with that stuff.
Great, thank you. I think that covered all of the questions that have come in, and I know we're already a couple minutes over our time, so I don't want to keep folks longer. But Dr. Falk, thank you so much for joining us, for Doctors In, and for sharing this wealth of information. I think there was a lot of really valuable stuff shared as part of these slides. So thank you very much. And thank you to folks who were able to join us today. I guess I would leave it to you, Brad, if you have any final closing words you would like to leave folks with.
No, I think I've said enough. I think everyone's like, dude, finish. No, I appreciate the chance to talk with everyone. And if there's any questions or anything, please feel free. David's got my contact information, so please feel free to reach out.